Hi, my name is Connie Clarness and you're watching the video on utilising prisms as part of managing a patient with strabismus. So far we've discussed the utilisation of prisms in the diagnosis or in the investigation of a patient with an ocular motility disorder. And here I've listed the various tests or investigations that you've learnt about so far where we utilise prisms to investigate strabismus. So we can use prisms to measure the deviation, either with the PCT, Krimsky or Maddox rod. We can assess fusion with the prism bar. We can look at motor fusion or jump fusion with the prism reflex test. We can put up a prism to neutralise the deviation and look for BSV. We can use prisms to map the strabismus. We can use prisms for preoperative assessment to determine whether a patient may experience diplopia postoperatively. We use prisms for the prism adaptation test. And finally, one we haven't looked at is that we can use prisms to assess fixation preference. So where a patient does not have strabismus, but it is suspected that they may have amblyopia, or you want to prove that there is relative equal vision, then we can use prisms to induce strabismus and then see if there's a fixation preference with that. We'll talk a little bit more about that a little bit later on. But you can see here that we can use prisms in a variety of ways to assist us in investigating and diagnosing a patient with strabismus. In most instances in the clinic, we'll be utilising a prism bar, such as we see here, or single prisms, but we also have the option of utilising Fresnel prisms. So here we have a single Fresnel, which is a press-on Fresnel that you put on a pair of glasses, and here you have a series of Fresnel prisms that can be put in trial frames. And these Fresnels range from around 1 diopter to about 40 diopters, so there is a good range of Fresnel prisms. We'll come back to Fresnel prisms in just a moment. Let's now move on to how do we use prisms for therapeutic management of patients. Generally, in most instances, we're going to prescribe prisms for patients to relieve diplopia. So patients come in with a complaint of diplopia and you find that you're able to give the patient BSV with a prism. You always prescribe the minimal amount of prism that gives the patient comfortable BSV. So as an example, if you have a 30 diopter esotropia, you don't simply give the patient a 30 diopter base out prism. You do the prism subjective, and if the patient can gain BSV with 20 diopters, that's what you give them. You give the least amount required for BSV and comfortable BSV. And here you just see I've given you an indication of the direction of the base for correcting a deviation in therapeutic management of patients. And it's the same as the direction of the base in measuring a deviation, such as in the PCT. Now, when we prescribe prisms in these patients, we have two options. We can either ground the prism into the glasses, which is a permanent type of solution, or we can use a Fresnel, a press-on Fresnel, which we put on the pair of glasses. That's a little bit more temporary in the sense that we can take that off and change it with any changes to the strabismus. So Fresnels are a really good option where we want to trial a prism to see if the patient is comfortable with that prism and then ground it into the glasses. It's also great if you have a strabismus that is changing or improving or worsening so that you can alter the prism strength. So if it's worsening, you'll increase it. If it's getting better, you'll be decreasing it over time. Okay, one other reason we prescribe prisms is to improve a patient's fusion and to improve BSV. So in this instance, we'll use prisms as part of a training or as part of orthoptic exercises. We'll come back to this when we talk about orthoptic exercises, but essentially we can train the horizontal fusion range, so fusion of convergence, fusion of divergence, and the vertical fusion range. So if we find that the range is low or below normal, and we think this is contributing to the patient having symptoms, then we can give orthoptic exercises using prisms to assist the patient. Now let's talk more about the Fresnel prism. The Fresnel prism is lightweight and thin, and here is a Fresnel as it comes out of the box. And so we can see here that there's a circle here, and what we do is we cut out a piece for a pair of glasses, and we can see here that Hillary Clinton has a Fresnel in front of the left eye, and so it's been cut from this circle here to fit these specific pair of glasses. So it's thin and lightweight, and as I mentioned earlier, it's a great temporary way of managing a patient with diplopia. So what is a Fresnel prism? Essentially, it is a series of prisms that removes most of the non-refractive portion of a conventional prism. So you can imagine it as it indicates here, that you have a series of prisms where you only include a portion of the conventional prism that is bending light. So here we have a conventional prism, and this shaded component is a refracting portion of that prism, and it is the thinnest component of that prism. And so the Fresnel consists of a series of that thinnest component of the conventional prism. And what we end up with is a very thin and lightweight prism because we're not including the thicker or the larger components of the prism. If we go back to that image of Hillary Clinton, you can see the lines of the prism. They correspond to the end of each series of prisms. If you take your finger and you run it against the Fresnel prism, you can actually determine the direction of the base of that prism. So if you can imagine here, if you run your finger along here, you'll feel a relatively flat surface. So you're running towards the base. If you go in the opposite direction, this way, you'll keep coming in towards that apex and feeling the base of each prism. So you should be able to determine the base of a Fresnel prism just by feeling it and determining which way is the flat surface and which way you experience resistance. Okay, I want to bring your attention to the impact of a Fresnel to visual acuity. When you put a Fresnel on a pair of glasses, there will be an impact on vision. It will also, however, depend on the strength of that prism. So the higher the strength of that prism, the more impact it will have on visual acuity. But you need to warn your patient that the glasses or the Fresnel on the glasses potentially will reduce their visual acuity. Now, in terms of fitting a pair of Fresnels on a pair of glasses, here is a list of what you need to do in order to fit the Fresnels. This is for your reference. I won't go over it in detail, except to say that clearly you'll start off with the entire Fresnel and then you'll cut it to size for the particular lens that you have. Before you cut it to size, you'll need to work out the direction of the base, how you're going to place it on the eye, and then go to cutting it. Now, because over time the Fresnel may come off the pair of glasses, you should actually train your patient as to how to put the Fresnel back on. And it's a good idea to mark a Fresnel, if you can, with a little dot so the patient knows that I need to have that dot in the upper right-hand corner, for instance, in order to have the base correct. Because once it falls off, the patient won't be able to put it back on unless you train them as to how that Fresnel needs to be on the pair of glasses. You don't want the patient to put the Fresnel back on with the base direction in the wrong direction, because obviously that's not going to relieve their diplopia. And finally, I want to talk about how we correct patients with both vertical and horizontal deviations with a Fresnel. Now, if I was grounding a pair of prisms for the patient, I might put the base out in front of one eye and the base down in front of the other eye. Split those prisms between the two eyes. We split prisms even when we have large amounts of horizontal deviation. So as an example, if I want to prescribe a patient 20 diopter prism base out, I have the option of either prescribing a 20 diopter base out in front of one eye, or I could put, as an example, 10 diopters base out in front of one eye and 10 diopters base out in front of the other. Now, a Fresnel, a single Fresnel, can correct both a vertical and a horizontal deviation. but we need to rotate it at a specific axis in order to correct both the horizontal and the vertical with a simple frenul. Let's take a look at an example. Here we have a patient who we want to describe a 6 diopter vertical prism and a 13 diopter horizontal. Now, one of the options would have been to put a frenul in front of one eye, the 6 diopter vertical, and put a frenul in front of the other eye, a 13 diopter horizontal. But like I said, we don't need to do that. We can actually use a single prism, rotate at a specific axis, and correct what is required, 6 diopters of vertical and 13 horizontal. To do this, we use what's called the nomograph, which we see here to the side. And it's available on the Fresnel Prism and Lens website, and you can access this at any time in your clinic. First thing to do here is to draw where the vertical deviation is on the nomograph. So here we have a 6 diopter vertical, and there's 6 diopters vertical. This is the vertical scale here. Here is 5 diopters, and this is 6 diopters. Then you need to draw the horizontal, 13. Okay, here we have the horizontal. Here's 10, 11, 12, 13. And what we see is an intersection that's here. This intersection is important in terms of now working out what prism strength we need. So we look for the closest quarter circle, which is the 15. Okay, 15 taken from here and here. So what we now know is that we need to apply a 15 diopter press-on frenul on the pair of glasses. The next question we have is at what angle, at what degree do we put this frenul in order to achieve 6 diopters vertical and 13 diopters horizontal correction. To do this, we now take the lowest component of the intersection, so here's the highest and here's the lowest, and we draw a line through the rotation angle. And what we have is that the prism needs to go through 23 degrees or be placed at 23 degrees in order to correct the deviation. And for confirmation in regards to what exactly you've corrected by putting this 15 diopter press-on prism at 23 degrees, we can just take a look at this point here where it falls on the horizontal and the vertical scale. Let's take the vertical scale first. We can see that we correct 6 diopters of vertical at this intersection point here. However, for the horizontal, we're correcting a little bit above 13, and specifically it's 13.8. Okay, the reason why we take the lower portion of the intersection and not the higher portion of the intersection is because it's more important to have accuracy on the vertical than on the horizontal. And the reason is that our vertical fusion range is relatively small. Remember, it's around 3 diopters base up or down. So we want that vertical to be corrected as best possible because a 0.8 difference on horizontal should be taken care of with the horizontal fusion range very easily. Okay, so at the end, in this example, what we have is the prescribing of a 15 diopter press-on prism at 23 degrees, and we end up correcting 6 diopters of vertical and 13.8 diopters of horizontal prism, which should be sufficient for the patient's requirements to gain BSV. Okay, that brings us to the conclusion of this video. Thank you for watching.